All right, so we'll do this kind of quickly. Review some of the quantitation guidelines for regurgitation, demonstrate some common echo methods. The approach to the quantification of MR starts really by thinking about what the mechanism is, thinking about the timing, and then ultimately incorporating all mechanism and timing considerations into your quantification of what the regurgitant lesion is. So we'll talk mostly about MR, a little bit about AR at the end. All right, so this is an interesting paper from several years ago. It was an inter-observer study, and basically they presented the same still image to a bunch of seasoned echo interpreters over and over and over again. And what they varied was, that's sort of the image, and all they did was vary what preceded the image and what followed the image. Sometimes they'd show the same image immediately, sometimes they'd precede it by a bunch of clearly severe MRs, sometimes they preceded by a bunch of clearly mild MRs, really just to sort of demonstrate that as an observer, if you're just looking at a color Doppler splash, you can be very influenced by what you've just seen. And the sort of take-home message from this one study was that only 1 out of the 12 observers gave a consistent grading when they were presented with the same image multiple times.
Was that you, Dr. Mitchell?
I was not a part of this study, but I would have been the one. Anyway, so this just emphasizing that this was done in the UK. Thankfully, I was not there. But we know this is one of the first studies to sort of try to quantify how difficult it is to reproduce a Gestalt eyeball for color Doppler. So one of the things to talk about is when you're looking at MR severity by echo, you got to think about both the mechanism and the timing. So this is an example of that. So this image on the far left, you see that there's some tethering, and I'll come back to this actual echo in another slide. But if you look at the color Doppler, we really only look at the color Doppler M mode for a discussion of the timing of the event. But here we see throughout all of systole, you've got a consistent flow. This is a different etiology. Hello, Dr. Zogby. This is a case of prolapse. So this is functional MR on the left, prolapse in the middle. This particular case of prolapse clearly has, again, holosystolic MR. But contrast to the far right case, we have prolapse. It's kind of late development of prolapse. And the M mode, color M mode, shows that the onset of MR is actually very late. So one of the things to consider is the timing of the event. So before you even start to do PISA or vena contractor or quantitative Doppler, do anything, when your first view of the event is what's the mechanism and what's the timing? So this is sort of an approach to the quantification. You're sort of looking at all these things. So is severe MR present? That's really the main question we're trying to answer. What's the mechanism? What's the consequence? So LA dilatation, LV dilatation, pulmonary hypertension, changes from previous studies. So you have to remember to think about not just give a quantification to the MR, but put it in context with everything else that's going on in the heart. And then ultimately the question that if you've got a patient in front of you is it time for surgery, and what additional data can I provide to the surgeon to ensure the repair success is over 95%, because that's really the expectation for a surgical repair. It's changed. It used to be 90. More recent guidelines expect now 95. So this is just an example of sort of gross, obvious pathology. You've got a posterior leaflet, prolapse with flail. Obviously a lot of color that goes with it. This is the other extreme, functional MR. Normal on the left, where cords are the right length, papillary muscle, they're in the right spot. You've got a nice coaptation zone. And notice really no visible tenting of the mitral leaflet in systole. Contrast this case, there's been a lateral wall infarct, infralateral wall. This piece of myocardium has displaced both apically and laterally. It brought papillary muscle with it. The chordae did not get longer to compensate, so now they're relatively too short. And the effect is that you get this sort of, in this particular view, you get a little buckling here of the anteromitral leaflet because it's now being restricted. It's not allowed to coapt appropriately. And if you were to look at this, you would actually have a measurable systolic tenting area underneath the valve leaflets. So this is the echo that would go with this image. So there's the 2D, and you can see this little sort of tethering of that the mid portion of the anterior leaflet. So that'd be the strut cord going into the mid belly of probably the center A2. And then the MR you get from that, in this case it's very eccentric if you want to pronounce it like that. But it's a fallacy to think that functional MR gives you a central jet and prolapse gives you a wall-hugging eccentric jet. This is clearly a case of regional wall motion with a wall-hugging jet. So forget the notion that the direction of the jet tells you its etiology. So the chords are relatively too short. This is another slide that shows that concept of tethering. So this is a case where there's clearly functional MR. And top one. There you go. If you measure a straight line across the annulus and measure an leaflet, it's a very clear tenting area. So if you can clearly define a tenting area, and there's been studies and shown using 3D echo that the greater the tenting area, the greater the severity of the MR. So that's one metric of saying, yeah, this has got a very, very tiny coaptation zone. The leaflets are just touching at their tips instead of along a long coaptation zone. So not only is there a mechanism defined clearly, but probably the MR is going to be significant when you see the leaflets barely touching like that. So emphasizing at the beginning really the concept of the reports, and it's amazing in the valve clinic we get these echoes from all over the place, and more often than not they have no mention of the etiology of the MR. There's a severe MR, sent for intervention, and nobody's actually bothered on the reports to say what kind of MR. Is it primary leaflet? Like these examples here where you've got this one's clearly got a P2, very large region of P2, but it's kind of a Barlow's. There's all kinds of lumpy, bumpy thickening of all the scallops. This was an isolated P2 with a flail chordae here, so that's primary leaflet failure. Primary ventricular failure, this is the functional case I showed you, tethered anterior leaflet. Some people would refer to this as pseudo-prolapse. You look at that and it looks like there's a little prolapse. The leaflets aren't touching at their tips, but neither leaflet is making it past the annular plane. So it's not prolapse in the classic sense, it's just pseudoprolapse or end-to-side coaptation, or it's just an asymmetric tethering. They're all sort of describing what's happening here. This is sort of the ultimate ventricular failure. This is a post-myocardial infarction papillary muscle rupture. You see that circular entity there is the end-on of the pap muscle. So wide open MR, primary ventricular failure.
See how fixed that posterior leaflet in the second base there?
Yeah. Yeah.
So I mean, if the anterior leaflet is moving, it depends on their length, and then there's coaptation. It's not prolapse, right? So
Yeah.
you can't call it.
It's not prolapse, but people often see one leaflet coapting behind the other, and they'll call it prolapse. The true definition of prolapse is supposed to be extending past the plane of the annulus. The plane of the annulus is way back here. So you could say it's prolapse relative to each other, but that's kind of meaningless. It's not prolapse. And then you've got what's clearly a mixed disorder. You've got lumpy, bumpy posterior leaflets, posterior scallops, but you've also got functional. There's no coaptation really anywhere along this valve. So the entity of a mixed disease does exist. It's becoming more important in the era of MitraClip. MitraClip is reimbursable for this or for this. We get a lot of referrals for this. And we have to tell the referring doc, well, it's not reimbursable. We can enroll the patient in the COAP study where they have a 50-50 chance of getting a MitraClip, but we can't just go ahead and put a MitraClip on somebody with functional MR and expect for the institution to be compensated for the intervention. So the sort of the labeling of the etiology does matter. All right, so 3D echo applications here. This is an example of the aortic valve. I want to see the disc come out of. Just 1 second. This came out of. All right, we'll skip that one. So just an example of 3D echo showing the MR here. So this is from the apex, looking up at the mitral valve. So just at the perspective, if you've chopped off the LV, you're looking up at the valve. The anterior leaflet here, you can see the mitral valve is wide open, but so is the aortic valve. So what happens is you get this sort of 3D color representation of the MR, very wide vena contracta in one view, more narrow in the other, an easily identified vena contracta area. This is really just to sort of show you some concepts. If you look at the flow convergence on this, it's this crescent-shaped flow, which is really one of the concepts behind the limitation of applying a PISA to functional MR, because no single radial measure is going to give you a hemisphere, or at least the concept of a hemisphere is not going to represent well this flow convergence. So you could measure a radius, and really that's the EROA you'd be trying to estimate using a PISA. If you just did a single 2D measure, you would not be estimating that effect. So the take-home message is for functional MR, PISA has a tendency to underestimate, because the assumption of a circular orifice, which is what PISA is based on, largely doesn't hold true if you've got significant functional MR, because the leaflets are pulled apart and you get this crescent-shaped defect. So People do it all the time. We do it sometimes because it's the only tool you've got. But you need to recognize that PISA for functional MR tends to underestimate. Okay. So we have these guidelines, and I think they've been around now 12 years, which is amazing. Dr. Zybri is now sharing the next iteration of the guidelines, and there's lots of discussion about how these are going to change, and how we're incorporating MRI into the decision process. One of the main things you need to be aware of is in the valve guidelines, the quantitation for functional MR has changed. So the valve guidelines now make a very clear distinction between primary MR and secondary MR. So our reports, and reports from all centers, wherever you guys end up, need to be very clear on what's primary and what's secondary. One of the main distinctions is the EROA. So an EROA of 0.4 or greater, so that's the size of the hole, centimeter squared, is the cut point for primary MR, to call it severe. But for functional MR, what's in the valve guidelines is actually 0.2, acknowledging that a smaller hole in a sick ventricle can lead to hemodynamically significant MR. You don't necessarily need to get to a hole of 0.4. We could probably talk for an hour about the implications for that and how you incorporate that into a lab, and if that's going to be universally adopted, or even how it's going to be adopted in the next version of the ECHO guidelines. But at this point, to let you know that it's out there, it's having clinical impact. We're getting patient referrals with EROA of 0.2, with an EF of 45%. Somebody says it's functional MR, and they want the patient to go to surgery. It's a challenge. There's rationale for it. We understand that less MR in a sick ventricle can have more hemodynamic consequence, but in terms of decision making around intervention, the data is less robust. Let's talk about some of the color Doppler specifics. So we've got this sort of all these different tools we can use. We've got the regurgitant jet area, the vena contracta, and the PISA. So we'll take a minute and talk about each of those. So color Doppler, remember, is a velocity map. It's not a volume map. So it's very important to recognize that. And when you're looking at it, you have to think about the factors that can affect velocity, because that'll affect the parametric display. So basically the software has taken velocity data, color-coded it, presented it to you in a way that's easy to digest, but there are limitations. Obviously, it's affected by the regurgitant volume, which is good. That's why we use it. But it's also affected by the driving pressure, or the velocity of the regurgitation, which is really affected by the transvalvular pressure gradient, the compliance of the receiving chamber, and the nature of the jet, whether it's a central jet or a wall-hugging jet. So this is the concept of flow momentum. This is the LV. This is the LA. The higher the pressure difference, the further and faster the jet will go. So if this pressure in the LV is 160 versus if the pressure is 100, for the same regurgitant volume, you can get a larger jet area. That's all that means. So it's important to look at that. And we rarely sort of acknowledge severe hypertension, but we see it all the time when you take someone to an intervention and they're under general anesthesia. The blood pressure drops, the MR looks better. That's the common application of this concern, is low blood pressure leading to low quantitation of MR. So this is an extreme example of pressure change. So this is usually a Friday night echo. Lumpiness, maybe someone's calling it endocarditis. Is the valve bad? You look at the color Doppler, it's not too bad. There's not a lot of color there. Not sure what that is. Draw blood cultures. You do the continuous wave Doppler. It's a very dense, triangular jet with a very low velocity, less than 4 meters, suggesting very little pressure gradient between the LV and the LA. No pressure gradient, big lump. What that is a papillary muscle rupture. So that's effectively one large chamber with blood sloshing back and forth, very low velocity gradient between the chambers, therefore very low, very unimpressive color Doppler depiction. So color Doppler is just velocity map, and there's situations where there may not be much velocity. Another example of entrainment, something else to consider. So the concept is blood that's already in the left atrium is forced to move, and it gets picked up by the blood that's entering the atrium. So this is the true regurgitant volume. And the black is sort of blood that was already in the atria, but it gets sort of pulled into the jet, kind of like a Venturi effect. So it adds to the regurgitant color jet depiction, although it's not truly regurgitant volume. So flow into the center tends to entrain other blood. So that's one of the explanations for the overestimation of regurgitant severity by entrainment of blood. That's non-regurgitant, but adds to the regurgitant jet. The other issue is the Coanda effect. You've heard this term. We see it all the time in life. This is an example when you try to pour water off a pitcher and the water wants to hug the side of the pitcher and leaves a big mess. So really, it's described by an aeronautical engineer. It's the tendency of a fluid to be attracted to a nearby surface. That's really the true sort of concept of Coanda. Where we use it is to explain sort of wall hugging. So this is, we see it all the time in planes. There's the jet wash comes out of the jet. There's often these little sort of deflectors on the wing. And what happens is this, call it fluid, air fluid, wants to hug the surface, and as it does so, it creates lift. So, engineers take advantage of the Coanda effect to help lift planes off the ground. Where we see it is in this situation. So the orifice here is going to be directed so the jet comes in and hugs the entire left atrium. Well, the whole entire time it's hugging the left atrium, you now have a fluid structure interaction. You have frictional forces that slow down the velocity of the jet. So the regurgitant volume now will be slowed by its interaction with the chamber, so the velocity map, which is color Doppler, is going to underestimate, to our eye, the regurgitant amount. So 30 mils straight into the LV, into a large chamber with no wall hugging, will have a much larger jet area than 30 mils that hugs the wall of the atria as soon as it hits it. One of the things is we tend to reserve the term Coanda for a jet that hugs the wall immediately. As soon as it enters the LA, it's hitting the wall. Not a jet that is slightly off-center. So fellows tend to say, eccentric jets, eccentric jets quite often. But really, unless it sort of hits the LA immediately as it enters the ventricle, it's not as much a big deal. It doesn't mean off-center. It means a true wall-hugging jet. And how do we deal with that? Basically, we have to do a mental fudge factor. We say, well, the jet's not that big, but it's hugging the wall the whole time from the very beginning. So we have to acknowledge that the color Doppler representation of the severity of this jet is tricky. We're probably going to underestimate it. We don't have a fudge factor yet to say we underestimate it by 20, 30, 40, 50%. We don't know that yet. We're doing some work on that, but we don't have that answer yet. Okay. So PISA, proximal isovelocity velocity surface area. The concept is really based on flow continuity. Effectively, if you know the surface area and you know the velocity of the flow and you know the velocity down here, you can solve for the unknown area, which is your EROA. That's the concept of PISA. Works a little like this. You always do the baseline shift in the direction of flow. So transthoracic baseline shift down, TEE baseline shift up. This is the math. 2 pi r, the radius, is this surface area, assuming a circular orifice and assuming a hemispheric jet, assuming a hemispheric flow convergence. So really, the concept is sound if you're applying most typically to primary MR, calcified MR, or you're more likely to have a roughly circular orifice. If you've clearly got functional MR, this first assumption doesn't work. So that's why you're going to underestimate it. But if it's typically a degenerative MR, roughly circular hole, that holds true. The regurgitant flow is the surface area times the aliasing velocity. The size of the hole, the EROA, is just the regurgitant flow divided by the peak velocity down here. And the regurgitant volume is simply the whole area times distance, which is the TVI of the jet. So that's how we get to PISA. That's sort of a quick application. For fellows, one of the challenging things is all these concepts, but really, if you just follow the units, centimeters times centimeter squared times centimeter equals centimeter cubed. So if you stop and think about what each of those measurements mean, you can sort of untangle the math and figure it out. Some examples, obviously the concept works just as well by TE, and you can do it. We don't tend to do it because we tend not to have circular jets or circular orifice by TE, but oftentimes we'll do it and it makes sense. The vena contracta concept is here. This in this little graphic. You've got a flow convergence. You've got a contracted flow after it goes through the orifice, so just distal to the orifice. It's not the anatomic orifice is here. The physiologic orifice is a little bit downstream and always a tiny bit smaller. How much smaller? The contraction coefficient depends on a bunch of things. It depends on the thickness of the orifice, the driving pressure, the actual volume. But in general, it sort of explains why the EROA is less than the anatomic or the AOA. In concept, the gradation is shown here of a vena contracta width greater than 7 millimeters is thought to be severe. That's on a zoomed view, so one thing for our sonographers is zooming is critically important to actually get a measurement of this. We don't do that as much as we should. And although the vena contracta in functional is sort of enlarging like this, the width is still proportional to the size of the hole. So vena contracta in functional, this may be 9 millimeters. The area may double, going from 7 to 9. So it's not a linear relationship with the area, but it's still proportional. The bigger the diameter, even in functional MR, the bigger the severity of MR. So I've already shown you we can do vena contracta in 3D. That's an example of that, and that's simply a direct measurement of that. One of the things we've done, and we're sort of working on, and Eleanor is helping us with this, is looking at sort of post-mitral clip when you have multiple regurgitant jets, and this is an example of a native MR, not post-intervention, with two discrete MR jets that sort of entangle up here, two discrete vena contracta areas, but the technical challenge is that they're very prone to any adjustments of the gain. And this shows that if you decrease the tissue gain on the left, the summation of the vena contracta increases considerably compared to this one. This is the same, and then this is high gain, it gets smaller. So one of the challenges is sorting out your settings so that you don't mess with the gain too much. The old standard, of course, is quantitative Doppler. We've seen this in many settings. It's basically area times distance equals volume. Area in, distance traveled in equals volume out. As I mentioned each year when I give this to the sonographers and to the new fellows to the lab, it's definitely worth pairing with the sonographer and asking the sonographer in several patients who don't have MR to get a sample volume, a pulse width sample volume at the annulus, so that you can go through and do the math with an internal control. Because most of the time our sonographers will appropriately get a mitral, annular, PW when there's significant MR and they know you're going to try this math. And they often won't do it if there's no MR. So it's a good exercise to go through and say, all right, well, in somebody who doesn't have MR, ask a sonographer for one day to give you a bunch of studies, and then do the VTI at the annulus, measure the annulus, get an inflow stroke volume, and somebody with no MR, it should equal the outflow, which is what you're often getting at the LVOT. But if you never practice it in somebody who doesn't have MR, it's unlikely you're going to get it right in somebody who has MR. And that's some of the math that we know. And this is an interesting study. Showed some of the limitation of this 2D approach. So how do we get these images for our outflow and inflow areas? Well, we know that's how we get the LVOT, and that's typically how we get the mitral annulus, and that's the measurement you make across the mitral annulus. And the mitral annulus is never circular, yet we assume it's a circle for the math, for the inflow math. We know from all the TAVR world we're doing and the CTs that the LV outflow tract is also non-circular, but we still assume it's a circle for the quantitative Doppler math. This is one study, sort of looked at that, the mitral annular area by 3D and the LVOT area by 3D, and they compared the 3D quantitation versus the 2D assumptions. And not surprising, there were fairly large differences. So for the mitral annulus, the 2D assumption largely overestimated the area compared to 3D. For the LVOT, the 2D assumption underestimated it. So perhaps these errors offset each other and you get pretty close when you try to quantify volume. But we don't really know that that happens all the time. This is not hot off the press, but it's sort of a work in progress. So this is an approach that we're discussing for the next version of the guidelines. So it's not going to be in the guidelines in this form, but in this format. But it's sort of a discussion around how you quantify MR and the various steps to go through, and importantly, sort of throwing up some cautions and where you need to know where to be careful. So starting with color Doppler, clearly severe criteria include something like 4 of these. So flail leaflets, vena contracta widths greater than 7. A Pisa radius greater than 1, and a Nyquist that's been reasonably reduced to 30 to 40. Big areas greater than 50% of the LA, pulmonary vein flow reversal, sort of the things that you typically associate with severe. If you got 4 of those, be pretty confident it's severe MR. On the other hand, mild is down here, so the other extreme. If you got at least 4 indicators that are all significant, they're all consistent with mild, it's probably mild. And then you've got sort of the quantitation, which is everything in the middle. Looking at deriving an EROA, regurgitant volume, regurgitant fraction. The final bins may change in their name a little bit. We end up with mild, moderate, moderately severe or moderate to severe and severe. But there are several cautions thrown up here. Caution one is be aware of these quantitations that assume a holosystolic event. If you're going to do a PISA, yet the event is only occurring at the very end of systole, PISA is going to overestimate the flow. So that's sort of the single frame concepts. Eccentric jets, easy to underestimate an eccentric wall-hugging jet, as we talked about. And then the idea of secondary MR here is if you quantify here, yet the etiology is functional MR in a ventricle that's 20%, that may have the clinical impact of being severe MR, yet it may have the flow quantitation of moderate MR. So these are the things that are the discussion which is ongoing and will be hopefully clarified dramatically for the next version of the guidelines. Just a final couple of words on AI, and then we'll let Dr. Nabi take the podium. Aortic, many of the same principles can be applied to AR. We have jet width. We have jet width in proportion to the LVOT. You can do a PISA. It's more difficult, clearly, to do PISA and AI, and that's why most of you haven't done it, or you don't do it on any routine basis. One of the main problems is that the flat assumption of the aortic valve cusps it's reasonable to assume a nearly flat line and then a hemispheric flow convergence on the mitral valve. The aortic cusps tend to be like this, and the PISA tends to be much more beyond. It's sort of like a pizza with one bite out of the bottom. It's not a hemisphere. So one of the major shape assumptions with PISA often doesn't hold true for aortic regurgitation. In this particular case, it actually did a pretty good job. That's why it became a slide, where it's flat, PISA. When it looks this nice, you can do a PISA and expect a reasonable replication of the flow volume. But these are the standard issues, concepts, typically much more focused on the vena contracted diameter for AI. And then the associated spectral Doppler. That's really where we all spend some time, is looking at the continuous wave Doppler, the pressure half-time, and very importantly, the flow reversal and the flow reversal pattern within the arch and the descending aorta. And I would say to the sonographers that's still an area where, in general, we could still do a little better, is consistent Doppler sampling of the arch in somebody who has AI. And then you can go through the quantitation of regurgitant fraction and volume. And the final slide, some summary points. So quantification of regurgitation is important both for treatment and for prognosis. Doppler stroke volumes are ideal in concept, but they're difficult, and you need to practice the math on people who don't have regurgitant lesions. 3D color Doppler can be useful, and this is for Dr. Nabi. Cardiac MRI may have an exceedingly minor role in the very distant future for a small group of pearl divers that can hold their breath for 5 minutes. There you go. Take over, Faisal.
Thank you. Okay, so I'll fill in the CMR portion of this talk, and I think comments first. No doubt about it. Transthoracic echo is the gold standard for valvular disease. It should be the primary imaging modality when it comes to the initial assessment and for any longitudinal assessment. There's a lot of advantages, as Steve has highlighted. I'll actually kind of move fast due to time, but you should know that this is also a Class 1 recommendation according to the guidelines. So what about cardiac MRI? Cardiac MRI, as you all have seen, is it more than pretty pictures? We have a lot of strengths and advantages that we have discussed previously. You have this large field of view, very high spatial resolution. You can image in multiple planes. It has been shown now to really be the most accurate for volumes and ejection fractions and quantitating flow. Compared to CT, it's completely radiation-free, and it potentially gives you not potentially, but it gives you information of myocardial viability, and how we can use that in our assessment of valvular regurg, is still being learned. So what is the role of cardiac MRI in valvular heart disease? Well, I think we've all seen echoes like this. I mean, obviously, if you have echoes where image quality is poor, this would be an indication to consider a second test, such as valvular heart disease. And for those of you who may attend valve clinic or have been in valve conference, frequently, there can be a discrepancy between what you examine, what your physical examination of the patient is, their clinical history, and what some of the diagnostic testing you're receiving. So you kind of need a tiebreaker or another test which may give you more potential insight. And I think, there's a whole host of issues which Steve also hit upon, where, echo indices kind of have difficulties, and we have to be aware of that. And this is, I think, a real role for cardiac MRI. For example, in mitral valve repair cases, is those who have mitral valve clip, those who may have multiple regurgitant lesions, those who have eccentric lesions, paravalvular defects, and specifically also late systolic mitral regurgitation, such as in patients with hypertrophic cardiomyopathy. I'm sorry, mitral valve prolapse. So just quickly to hit upon what the guidelines state, you can see here, this is all from the 2014 guidelines where Dr. Nishimura is the lead author. For both primary and secondary mitral regurgitation, CMR has a class 1 indication, and usually when issues are not satisfactorily addressed by transthoracic echo. So how can cardiac MRI help us? And my next few slides will kind of, really hone in on these main points. Well, number one, as Steve had discussed, is, we have to, it's more than just severity. We have to kind of understand what the mechanism is that's leading to the regurgitation. We have to be able to assess the severity of the lesion and give it a grade. We have to assess the hemodynamic consequence of this lesion to the ventricle. So what are the volumes and function? And now, possibly being explored, how can late gadolinium enhancement and other methods to assess fibrosis, such as T1 mapping and ECV, how we can kind of incorporate these in our assessment of our patients. So why are these important? Well, if this is just taken straight from the guidelines, as you well know, when it comes to deciding treatment and management of your patients, it all comes down to, differentiating primary from secondary mitral regurgitation, knowing your MR severity, knowing what your symptoms are, and then also knowing what the LV response to your mitral valve lesion is. And I think these were probably hit on during Steve's talk. So, well, when it comes to mechanism of mitral regurgitation, these are just a few example slides of different cases of mitral regurgitation seen by CMR. Unfortunately, my movies are having a playing problem. But RT's, yeah, if you don't mind, if you have any input into as to why.
Let's try to duplicate it, and that might do it.
Well, the main point of that slide is, No?
Mm-mm.
Okay.
Sorry.
Interesting. All right. PowerPoint. But, a lot of the main pathologies that we're interested in, we can definitely assess with cardiac MRI. For example, functional MR, where your valves are, where this is really a problem of the muscle and your leaflets are tethered, can very well be seen by CMR. Restriction cases where the posterior leaflet may not work well. Cases where there's coronary artery disease, again, also another example of functional mitral regurgitation, where you have a wall motion abnormality and, a possible papillary muscle infarction. And here, a case of mitral valve prolapse. But these aren't only the range of mitral valve morphologies we can see. These are just more examples of some of the things we can see, such as hypertrophic cardiomyopathy with SAM, parachute mitral valves, and a rheumatic appearance of a mitral valve with doming, and of course functional mitral regurgitation, as we suggested. With CMR, you have the ability to be able to interrogate all the different coaptation interfaces. This can be done simply as seen here. You have a short axis en face view of the mitral valve. By creating multiple different slice locations, interrogating the different scallops, you can actually interrogate where your pathology originates and where the mitral regurgitation jet also originates. And I'll show you an example of that if my movies play in the future. When CMR has been compared to TEE, it's been, I think, it has a fairly good accuracy for detecting malapposition, or specifically situations of prolapse and flail. These are macroscopic events, so we have the temporal resolution, spatial resolution to be able to see them. Where we have difficulty is and where we're inferior to TEE is when it comes to depicting chordae. For example, those structures are very, very thin, they're very highly mobile, and the way our images are created, which are usually created over several heartbeats, we can completely not see our tone chordae. There have also been, CMR can also be helpful in looking at the regurgitant orifice and trying to determine what the etiology of the disease is. And these are just some examples, but the main point I'd like to hit upon is what Steve was mentioning, was with functional mitral regurgitation, your anatomical orifice is actually crescentic shaped, and you can actually see this very, very nicely with CMR, rather than being a pinpoint hole. So when it comes to assessing the severity, that was a lot about mechanism of mitral regurgitation. What about severity? When it comes to assessing severity, there's actually two different sequences we have to use in combination to be able to determine an answer. One is our cine views, where we image the heart from base to apex to determine of function and volumes, and then phase contrast CMR, which we use for flows. So this is just an example of how we go about tracing our heart at end diastole, and then again at end systole. We do this from the base of the heart all the way to the apex. There are no geometric assumptions that are made, so this is the true Simpson's methodology. And once you've traced the ventricle at end diastole, you have an end diastolic volume. You trace it at end systole, you have an end systolic volume. Obviously, the difference then is the LV stroke volume, or the total output that this ventricle is able to achieve. This methodology, in some future slides I'll show you, is extremely accurate, and I'll show you what it's been referenced against. But it can be very helpful, when you're making the initial assessment and impact of any regurgitant lesion, as well as with long-term serial measurements, whereas with echo sometimes it can be difficult to get a true feel of whether there's a true feel of whether the ventricle is enlarging or shortening. So here is just an example of all the methodologies CMR has been validated against. Volumes. You can see here in the specific study which compared CMR volumes to casts of cadaveric hearts. The relationship is extremely tight. It's been studied in animals, in vitro setting, in vivo, ex vivo, and really has been shown to be superior to echocardiography. When it comes to assessment of LV volumes and ejection fraction, really the inter-observer variability is the lowest of all the techniques. They're around 2 to 7%. 2D echo volumes, can frequently get into trouble for a couple of reasons, mostly because of intraoperative variability, foreshortening views, and the reliance on geometric models. When it comes to tracing out the right ventricle, we can do this as well. Again, you're able to see the right ventricle in its entirety. And here, again, it has been shown to be highly reproducible with low interstudy variability, and it's been shown to be superior to echo. However, its interstudy variability is higher than it is on the left side, and that's mostly because of the trabeculations and sometimes trying to decide where the right ventricle actually ends. This was just a study looking at the relationships of volumes with echo, 3D echo, with and without contrast. And for the sake of time, you can see the volumes that you derived by cardiac MRI tend to be much larger than volumes derived by transthoracic echo without contrast, but improved when you do give contrast. So the importance, I guess, when it comes to if you're going to use echo for volumes, it's very important to give contrast. The next portion of the sequence, in order to define severity, we need flow information, and flow information is really obtained by our phase contrast CMR. Phase contrast CMR, we won't get into the physics too much, but know that as blood moves through the magnetic field, moving blood achieves a shift in a phase shift, which is proportional to the velocity of blood. This phase shift is then displayed as a difference in signal intensity. So you can kind of think of it as, oh, interestingly, this movie plays, okay. You can think of it as our echo Doppler. We have two ways of examining flow of a velocity map. Either you can look at it in plane, or you can look at it as a through plane. For example, here is a through plane through the mitral valve. And the way, instead of colors, where this is actually a grayscale, where bright colors are in the direction of the phase encoding jet, whereas dark colors are in the direction opposite to phase encoding jet. With CMR, you have to choose what's known as a maximum velocity, or a VENC, has to be programmed into the scanner, and this is really just a velocity where aliasing occurs. And the idea is to choose an aliasing velocity where there is no aliasing occurring, but not a velocity so high where you kind of have noise and you lose the dynamic range of the images. When it comes to flow, the most important point really of this slide is that for flow we have to do through plane imaging. And this would be just a good example of that. For example, y'all all know this equation, flow equals area times velocity. With CMR, we can create a slice location, for example, here in the ascending aorta, where we have a prescribed area. You can then measure the velocity of each of the pixels. And if you integrate this information, the velocity of each pixel and its area over time, you can, for each cardiac cycle, you can actually create a flow curve, both of forward flow and regurgitant flow. So you should know that these flow curves that are derived by CMR also have been shown to be accurate. They have been tested in vivo with LV stroke volumes in patients without mitral regurgitation. They've been compared to thick and thermodilution and echo Doppler, and also in flow patterns. These flow measurements, because they're done in the through plane location, tend to be less angle dependent than echo Doppler measurements, and they generally say around 15 to 20 degrees is okay. But I think we've all seen one limitation I think we're all aware of is, yes, since this information is created over multiple heartbeats, that if you have very irregular rhythms, such as patients with uncontrolled atrial fibrillation or frequent PVCs, this flow information can be problematic. This is just a slide to show you that, when it comes to, and Steve kind of mentioned on this, when it comes to determining flow with echocardiography, and here's your formulas up front here, there are a lot of quantitation that goes into these, and therefore a lot of room for error, especially when it comes to making measurements of the diameter of the vessels, because specifically this number is squared and therefore can introduce significant error in your measurements. So when it comes to quantitating mitral regurgitation, how do we do this? I think the concept, we use a method called the indirect method. And if you'll just imagine with me, if you know your LV stroke volume, again, which is really the difference between the volume of your heart in end diastole and end systole, it is therefore the volume of the what the LV is able to push out. Now there's two places it can blood can be displaced, either out through the aorta, which we can easily measure, or into the left atrium. So if you know how much blood is displaced, which is the LV stroke volume, and you can measure how much flow is going out through the aorta, the difference therefore is your mitral regurgitation. One of the things that I like about CMR is its ability to have some internal checks, if you would like, to make sure that your numbers that you're reporting are reasonably accurate. Now, as you know, our preferred method is this indirect method where we compare the stroke volume to the aortic forward flow. But we have these internal checks. We can do what the echo people do as well. We can compare our mitral inflow to our aortic stroke volume. If any of these measurements are problematic, we can even compare our LV stroke volume to our pulmonic stroke volume, or worst case scenario, just simply comparing our LV stroke volume to RV stroke volume. So these are a bunch of internal checks. Worst case scenario, if we have a lot of difficulty, let's say with flows, arrhythmias, in the end we can still, as long as there are no other valvular regions or intracardiac shunts, we can simply compare the stroke volumes of the two ventricles to get a very reasonable assessment of the degree of their regurgitation. The indirect method, this is a long slide just showing a lot of the advantages and disadvantages, but just to hit upon some of the disadvantages, sure, it can be challenging, to say the least, if you have multiple lesions or shunts, if you do not properly planimeter your ventricle, if there's any inhomogeneities in the magnetic field which can cause errors. This is, your flow has to be orthogonal to your slice position, otherwise you can introduce errors that way. And if by chance you have flow that is not truly perpendicular to the your slice location, then of course you can underestimate flow. Now, CMR, this direct method and indirect methods, this is just a long list of tables which all have access to, showing how CMR has been compared to both transthoracic echocardiography. It has using multiple methodologies, such as similarly compared to PISA, volumetric, LV stroke volume minus aortic forward flow, so multiple ways it's been compared to echo. It's been compared to TEE, and all of these have shown relatively high accuracy and diagnostic agreement. Until this paper came along, and I'll mention this because this is some new data that we've seen from 2015. And this was a paper which looked at a small number of patients, 103, and I believe this was probably discussed at one of the journal clubs as well, where they looked at 103 mitral regurgitation patients and who had both transthoracic echo assessment of MR, and in this case they used PISA with cardiac MRI. And what they found was, if you look at the regurgitant volume that was achieved by echo with and compared it to MRI, you kind of see a scattered plot, and really we're not the most tightest relationship if we were just to look at the points that have been plotted. And if you look specifically then at the differences between the echo regurgitant volume in a bland Altman and the cardiac MRI regurgitant volume, you were seeing differences of almost 30 mils plus or minus. And this was a nice little graphic over here, just kind of displaying in these patients with chronic mitral regurgitation what percentage is then mild, moderate or severe by MRI, and you can see quite a significant difference visually compared to what was obtained by echocardiography using the PISA method. What was interesting about this technique was they then went on to about 38 of these patients went on to have mitral valve repair or replacement, and of these 26 actually had an MRI performed 5 to 7 months later. And I think the concept is that what their theory is that, well, let's say if you have 60 degrees of regurgitant volume from MR, and so theoretically your left ventricle should dilate by at least 60 mils to handle this load. So the idea is to see what change in your end diastolic volumes in your patients who followed up post-surgery, to see whose volumes, as the heart remodeled, whose volumes did it more match, the regurgitant volume from the transthoracic echo or the regurgitant volume from the cardiac MRI. And if you look at the plot graphs here, This is cardiac MRI on this side and echo on your right-hand side. You can see the relationship between the post-surgical decrease in LV end diastolic volume and your mitral regurgitant volume as predicted by CMR were much more, you had an R value of 0.85, whereas with echo, again, you had this very large scatter with an R value of only 0.3. So, and this was kind of a paper here, this was kind of a little bit summary here, the ventricular response to isolated MR, that just showing by CMR that, you had a much more significant decrease in end diastolic volume by CMR if you had severe mitral regurgitation by CMR, whereas it was much less whether you had mild, moderate, or severe by transthoracic echocardiography. And so in this paper, they suggested that MRI is more accurate than echo in assessing the severity of MR. Now, yes, I'm sure that this paper does have faults in it. It's a small number of patients, and more importantly, they used PISA, whereas we know there's multiple ways you can accurately identify, quantitate mitral regurgitation. This is just one paper, another paper that again looked at a small group of patients but who had transthoracic echo and CMR the same day, 2 readers, and what they found, whether you're looking at aortic insufficiency or mitral regurgitation, when it came to serial measurements between these 2 readers, CMR had a much more tighter relationship than 2 independent echo readers. So giving you the sense that when it comes to repeated studies, if you use CMR, you can be more sure that the change or lack of change that you're seeing is real. People have used other methodology with CMR to quantitate mitral regurgitation. If you can measure flow anywhere, why not just measure flow at the annulus and see how much blood is coming back? And people have done this. This is just an example of that. Only why we don't necessarily use it is because you can imagine you're creating a slice location at the annulus, but if your heart is descending, then there's a portion of time when you're imaging where you're actually imaging the left atrium and not truly the mitral annulus. So this actually underestimates flow, but it can definitely give you a good ballpark number. People have looked at vena contracta measurements using cardiac MRI. This has its own difficulties. They've done it with gradient echo. We don't necessarily do it in our lab. You really have to have good slice locate position. You really have, there's partial volume effects. Not a reliable methodology, but has been looked at. This is a nice paper. This was in that was looked at actually using an anatomical regurgitant orifice, where you find, you create multiple slice locations through your leaflet tip and actually find the smallest maximal opening and trace that. And this is not an effective regurgitant orifice, but rather an anatomical orifice. And here they found a similar cutoff that of about 0.4 had a high sensitivity specificity for Seller's angiographic grade 3 or 4 MR. So, we can use, apart from volumetrics, some other tricks potentially to also help quantitate mitral regurgitation. So I'll move a little bit quicker on the cases. This was just a case. If you look over here, your 3-chamber, if this movie would play a little bit faster, it looks like an anteriorly directed jet. One of the no problem. So one of the nice things, again, we mentioned about CMR is to be able to look at many of the different interface, the scallops of the mitral valve. And in this particular case, if you look closely at the A2P2 interface, which was not seen in the A1 or A3, there was a flail leaflet. When it came to quantitation, it was similar to what we had discussed. We had the LV stroke volume here, which was 145 mils. Our aortic forward flow was 65 mils, which is, and this is just a a readout of this graph. And so if you subtract 65 from 145, you get 80 mils. Take the 80 mils, divide it by your flow across the mitral valve, you got a regurgitant fraction of 55%. Where it can also be very helpful is in cases with concomitant AI. When you have concomitant AI, it can be very difficult to quantitate by echocardiography because the continuity equation fails, and you're only left with qualitative measures. The good thing with CMR is that the indirect method applies even in the presence of aortic insufficiency. And the reason is because aortic insufficiency actually contributes both to the LV stroke volume and to the aortic flow. And therefore, they cancel out each other when you subtract the two numbers. Can be very helpful in multiple mitral regurgitation jets. As you can see, the difficulty we can have in patients who are post-clip. And in these cases, at least for 2D measures, it can be very hard to apply vena contractor or PSAS. Secondary MR, I think CMR can also be very, very helpful. Here's an example caused by coronary artery disease. And one by just a non-ischemic cardiomyopathy. Here, this is a problem of the muscles. Your papillary muscles have been displaced laterally, and you actually have, these chordae, as Steve says, are too short now for the ventricle. They're tethered, and you get a mitral regurgitation. This was one interesting study that I came across, which actually tried to look at Okay, this is just one study that, how we may be able to use delayed hyperenhancement in the future in valvular cases. So this was a population of patients who had mitral valve prolapse. And what they found was they found areas of these in these patients where you could identify either partial or complete papillary muscle fibrosis. Now, this was just, it needs further, obviously, long-term outcome in a larger group of studies. But what they very interestingly showed was that in patients who had significant ventricular arrhythmias, it was mostly those patients who had late gadolinium enhancement in their papillary muscles. So, stay tuned for this story that, there may be other ways we may be able to assess risk in patients with mitral regurgitation due to mitral valve prolapse. This was another study that I came across where they tried to look at how delayed enhancement can be used to identify mitral regurgitation and partially give insight into the severity of mitral regurgitation. And so what they did was they looked at papillary muscle infarction, whether it be none, partial, or complete. And what they found was in patients who had greater severities of papillary muscle infarction, you had increasing infarct transmurality, you had increasing maximal infarct, mean and maximal infarct transmurality, you had increasing wall motion scores in those patients who had, greater severities of papillary muscle infarction. And when they looked at prevalence of mitral regurgitation, they found, patients with complete papillary muscle infarctions had much higher degrees of mitral regurgitation. So that was one interesting finding. But when they went on to look at where the infarct was, if you had an infarct location in the lateral wall, you were much more likely to have mitral regurgitation than in other territories. And so, as you know, CMR can be a very valuable tool with delayed hyperenhancement to identify areas of myocardial infarction. When they placed this in multivariate regression model, the only things that came out significant for identifying significant mitral regurgitation were really a lateral wall infarct and the mitral annular diameter, and kind of the papillary muscle infarction story fell out. But, I thought it was interesting. At least it tells you that, if you have a lateral muscle infarct, the greater the severity of infarct, more chances you're going to have papillary muscle problems. And it makes sense that those patients should have worsening in mitral regurgitation. There's been a lot of work now in trying to because the guidelines are now pushing for operating on patients earlier in time as long as you're at centers of excellence. There's been a lot of work on how we can identify patients with, asymptomatic severe lesions who are more likely to progress and therefore good candidates to operate sooner. Now there's a lot of clinical evaluation, exercise treadmill testing, there's blood work being done, BNPs and the like. This was one study that looked at, how about using myocardial ECV, which is a method of looking for diffuse interstitial fibrosis. And what the study showed was that, myocardial ECV in this particular study was associated with increasing LV and systolic volume indexes, increasing left atrial size indexes, lower ejection fraction, lower longitudinal function, and a lower peak VO2 max, indicating that once you've detected fibrosis, this is an abnormal finding for this heart. This is a pathology, and it goes along very nicely with a lot of clinical indices. So there's now work, and our group as well has been now actively looking at how we can use this data. Is it more robust than just our current clinical evaluation in identifying patients who should be operated on sooner? This is just early work. I think AI we didn't discuss, so we will hit that another day.